cardiologist with Gutwell Medical, and I am on my way up to Loveland, Colorado to get a CTA of my heart, and that stands for CT angiography of the heart. I have had this test done before. I've actually had 3 of them done in Colorado Springs at the Penrose Hospital. My cardiac journey began when I was just starting functional medicine and happened to do a full lab panel and found out that I am a carrier for little a lipoprotein, which means I have very high amounts of this type of LDL that puts me at a much higher risk for heart attacks and vascular disease. My mom had a heart attack at 62, and so when I was 62, I got this full lab panel done, and then I also went ahead and had my first CT calcium score. And a CT calcium score looks for calcifications in your coronary artery, but a CT calcium study can only detect hard calcified plaque, which that is the plaque that is along the vessel wall. The plaque that we're most concerned about in terms of heart attacks is what we call soft plaque. And soft plaque is what protrudes into the lumen of the artery and can actually occlude the artery and cause an acute myocardial infarction. So anyway, I had a CT calcium score, and the only blood vessel that showed up with calcifications was called the right coronary artery. And this was the same artery that my mom had a heart attack. This was the artery that occluded and caused her heart attack. So I was therefore very alarmed that my calcifications only showed up in this blood vessel. And so then my next step was to get what's called a CT angiogram. And I went to one of the local hospitals in Colorado Springs at Penrose, and I had that done. I did not have any significant narrowing at that time. The narrowing was less than 15%. The next year, I was still very concerned about having a heart attack, so I did it again. And the 3rd year that I did it, just again for screening purposes, I wasn't having any symptoms. This time it showed an 85% occlusion in my right coronary artery. And of course, I was scared. I mean, that to me told me that had developed within a year. My LDL had always been around maybe 140, but my little a lipoprotein levels were around 200. I made an appointment with a cardiologist. I went in to see him, and we discussed the options. I was given the option of doing medical management, but I was also given the option of maybe doing a heart catheterization, as ever since I found out about that narrowing, I was having chest pain, but I wasn't sure if it was anxiety or, cardiac ischemia. So I opted for the catheterization. I went in, I was given anesthesia. They went through my radial artery in my wrist, went up into my heart, shot dye into my coronary arteries. And then when I woke up after the procedure, I was told that my arteries looked good and that the occlusion that they saw was a false positive. I had actually been reading Peter Attia's book at the time called Outlive, and he mentioned that it's important to know how much radiation exposure you get when you do a CTA of the heart. So I called the hospital, and nobody could really tell me how much radiation I had been exposed to. The way they express radiation, it's called millisieverts. A normal CT abdomen and pelvis is about 20 millisieverts. And when I asked the radiologist, their best calculation was that I probably got the same amount of exposure. So the reason I'm driving all the way up to Loveland is Clear Heart and Lung has a machine called a single beat CTA. So this means that in the time it takes for my heart to have one heartbeat, the machine is so sophisticated that it can capture all those images within a single duration of my heartbeat, and it will be able to reproduce the images showing me whether or not I have any narrowing in my coronary arteries. So I will learn a lot more about this today. After I have my CTA done, I have an appointment scheduled with the owner, and I'm I'm excited to ask her questions and learn more about this technique and be able to present this information to my patients. I have sent patients up to this facility to have this test done, but this is my first time to actually visit the facility and have the test done. I am here with my Labrador, Blue, and my other dog, Tux. He's in the back seat. We are all taking a road trip together today. Stay tuned. I'll show you the facility as soon as I get there.
Right before the test, we give some nitroglycerin. That one is a vasodilator, so it does lower the blood pressure for about 5 to 10 minutes. What we're doing there is just trying to open up all your vasculature and capillaries for that contrast dye to get in, essentially so we don't miss anything.
And what were you saying about the heart rate?
So the targeted heart rate is 60 beats per minute or less. And the reason why is because it's a cardiac thoracic dedicated scanner, so we can take a picture of a beating heart. It just needs to be a little bit slower. So 2 medications that we use is metoprolol, which is a beta blocker. That one pretty much just activates your rest and digest phase instead of your fight or flight. So it just tells your heart, hey, let's slow down for a little bit. Half-life on that is kind of odd, it's 3 to 5 hours, but people get it prescribed to them for speech anxiety or just anxiety in general. All in all, it's you should be leaving just as good as you came in.
Great, thank you.
Yeah.
So, hey Kim, how do you feel about the CT calcium score? I mean, since you guys are doing a CT calcium score that comes with the CTA, what do you guys notice when you get the CT calcium score, and then what does the CTA show?
Okay, yeah, it's super good question, because there's a lot of misconceptions out there about how much information a CT calcium score can provide a patient, and the answer to that is it's very limited amount of information. So we've had patients who've come to our center because, like you said, every patient gets a calcium score with the CT angiogram. We've had patients that have come that have had a 0 calcium score that went straight to the cath lab to get a stent. So these were patients who had all soft plaque that would not have showed up on a calcium score. So calcium score only shows old calcified disease, and so everybody has a different mixture of soft versus calcified plaque. There are those that obviously have a significant amount of soft plaque and very low or no calcified plaque. So I think that we've had patients that have also come in that have had a 2000 score that had 50% stenosis. So one would say that patient you would have thought would have been on the brink of a heart attack with a 2000, but their disease and their calcification was all evenly spread out on all vessels. So the total count was high, but it wasn't all in one place. So calcium score gets a limited amount of information.
And my understanding is the calcified plaque that shows up with the CT calcium score is hard plaque that's along the vessel.
Yes.
But it's not like the soft plaque that protrudes into the middle of the blood vessel, which actually occludes it.
Correct.
That's where you get your clot and your occlusion, which then causes a part of the heart to be ischemic and die, which is what an MI is, or a myocardial infarction.
That is correct.
Okay.
Additionally, that soft plaque that's in there oftentimes is just barely hanging on to the vessel wall. So if a patient has an increase in blood pressure, that breaks off and goes downstream, causing a total occlusion downstream. So heart attacks can happen slowly and over time due to gradual buildup of plaque, or because of a plaque rupture that occurs.
What are you seeing right now in terms of insurance coverage? I know that Medicare covers a CTA if they have certain symptoms.
Correct.
Right? They don't cover it for screening.
Correct.
What do you see on the horizon?
Well, I know there's clinical trials being conducted today to prove that coronary CT angiography should be used as a screening tool. I think we're at least 5 years or more away from seeing a ruling like that. I also think that we have some political barriers that we're up against that will be challenging to get. It's challenging to get anything that's offered as a screening tool approved because it's so costly to insurance companies and to Medicare.
Right.
Yeah, so Dr. Brudoff is my reader, and he sits in a room with 25 students, which are cardiologists from all over the nation, who come to him for a 1-week course. And so he brings the study up, 25 cardiologists read your patient's studies, and then he tells them if they're right or wrong, basically. And so it's a great environment, and it's really ensures, with that many eyes on it, it ensures accuracy. And he did a lot of the clinical trial work that was responsible for proving that coronary CT angiography should be used before nuclear stress testing, before stress echo. Those are about 70, low to mid 70% accurate, and this is high 90% accurate. See, it's just that the hospitals haven't adopted the use of it because it's not a moneymaker for them. So when we do the most accurate test first at a hospital system, they make the least money because they can't put you through a battery of unnecessary tests. So I'd say the other major value to patients is that so many patients, I was a cardiovascular service line administrator, which means I got to see what every patient was billed. And so over half of the patients we sent to the cath lab didn't need to be there. There were patients that went there for a look and see and never got a stent. But that's a $10,000 procedure, when if you had this test, we could tell you don't need to go to the cath lab with 99% accuracy. And so again, another reason why healthcare systems don't want to do it, because
It's not generating money.
it's not.
Yeah.
So on top of that, the other major political barrier, probably even bigger political barrier, is that insurance companies don't want to cover it because it diagnoses your patients with heart disease early, so you can treat them proactively, but they won't die of their first heart attack. The cheapest patient to an insurance company is a patient who dies from a condition that patient never even knew they had, because they didn't pay a single claim on cardiovascular disease for that patient.
That's so interesting.
And that's when I started to see those political barriers, and it gave me less and less hope that we would ever get to a place where we were preventing heart disease in America, that we would just continue to wait until people, had chest pain. And by then, they have 90% plus blockage, and I want to find those patients when they're 30%. So you can work with them to keep it there.
Right. And so I send patients up here because my understanding is this what's called a single beat?
It is.
A single beat CTA, meaning the time it takes for my heartbeat to beat one beat, you're able to capture all the images.
That's correct.
During the duration of that.
That is correct. One cycle. So
how much radiation do you think an average person gets?
1 to 3 millisieverts on this scanner, and an average of 16 millisieverts on a hospital scanner, an all-purpose scanner, which takes 6 seconds to acquire the whole heart. Several rotations, and ours takes a quarter of a second to acquire the whole heart. And so that, coupled with a smaller detector, means that all of your organs, just your heart, is getting the radiation that is required to get the image, not all of your organs with a wider field of view.
And how many of these type of scanners are available in Colorado?
2. There are 2 now. There's one
in Denver?
Yes.
At the Boone
It
Vascular Institute?
Yep.
And yours up here in Loveland?
Correct.
Okay.
And I don't know if Boone does any,
open access?
Correct, because they're definitely looking at a whole different patient demographic than the average patient. And so,
when I've looked at his website, it looks like you need to enroll in a program for that, and so that's why I send patients up here.
And we have patients who fly in from all over the U.S. to come here. People who do their own research like the fact that, yes, there are other single beat scanners in the U.S., but they don't get Matthew Budoff to interpret their study. And we really pride ourselves on only doing the tests that are necessary for the patient. If a patient has moderate disease, we do recommend a plaque analysis. If a patient has severe disease, we do recommend ischemia, which that's the piece of the AI test that tells us, does this patient need to go to the cath lab or not? And so, but we don't just do all 3 of those on every patient that walks through the door. We have certain criteria that our doctors follow when they read that says this patient would actually benefit from this test.
So I'm going to get the CTA today, which is putting the dye through an IV. It will light up my coronary arteries. And then if I have moderate soft plaque,
Correct.
present, then you would take those images and they would be fed through an AI company that then analyzes the plaque.
That's
Is that
correct,
right? And tells
yes.
you whether or not this is a high-risk plaque or a stable plaque.
Yes, and it also tells you the exact location of the plaque, because
Okay.
certain locations are more risky than others. You have a lesion that's more proximal, obviously that's risky if you have a distal lesion. So it really allows you to comprehensively quantify your patient's risk of having a heart attack, and if they have a heart attack, will it likely be a fatal heart attack based on
Yeah.
that additional information.
So what I think is so exciting about this is when you read Peter Attia's Outlive book, he talks about the CTA and says you should have this done in a facility where you get minimal radiation exposure, which
Yes.
is exactly what Clear Heart and Lung gives you.
Correct.
Yeah, that's,
Yes.
from my experience, I only knew of this facility that I was open access and I could send my patients to, so. Anyway, thanks for having me. I'm glad to be up here today.
Yes, thank you for coming.
Yeah.